Hello, welcome to our MMIs. Thank you for joining us this afternoon, as every week. My name is Dr. Valeria Duarte. I'm one of the adult congenital cardiologists and cardiac imagers at the Houston Methodist. I'm surrounded here by all my star fellows. Today we're going to talk, this is the first of a series of 3 talks on congenital heart disease imaging. And the first one, we have to touch on simple congenital defects. And I always tell my fellows that there is no such thing as simple congenital heart disease, truthfully. So we're going to learn how to comprehensively evaluate these defects. Today, we're going to focus on atrial septal defects. My fellows here in the audience are very familiar with this and very comfortable with this, so they're going to help me make this a little bit more interactive. I'm just waiting for some of them to sit in the front row so I don't feel lonely. Okay, so let's get started. So whenever we talk about atrial septal defects, it's very important that we remember how atrial septation happens during embryologic development of the heart. And I won't bore you with all of it, but I just want to make sure I show you. Give me 1 second. Tyree, I need to be able to show my pointer in the screen. Is that feasible? Can you all help me do that? I don't mind if here you do duplicate. I don't need. Yes? Oh, great. Perfect. So I won't take too much time discussing this, so let's just focus at 60 days in the development. You can see here what is the growth of the septum secundum here in yellow, yeah? And then the fully developed septum primum, yes, and you see there is some overlap there. In this area here, it's called the fossa ovalis, say my fellows. So when we have a defect in the fossa ovalis, what do we call that defect, that atrial septal defect? In the fossa ovalis, let's say there is a missing piece. Yes, say it. Secundum ASD, good job. So the secundum ASD is, and this is like a little words, the words get confusing, but we say that if there is a defect here in the fossa ovalis, we're going to call that a secundum ASD. And the secundum ASD is a defect in which septum? Primum, yes, that's correct. So just whenever you're labeling these defects, just make sure that you keep it simple and you call it secundum ASD, as opposed to trying to explain which septum is deficient, because you may generate confusion that way. Okay, so all right, so let's review. Whenever we image the atria, we need to just be aware of all the anatomic findings. Okay, so I'm gonna need help from my fellows here. So you can see this is the right atrium, right? What is this right here? The fossa ovalis. Louder, please. And what is this here? So this is called the superior limbic band. This is the septum secundum, right? We were looking at it here in in a 2D, but truly is like an arcade, yeah? So you can see it here like that. And I'm just pointing that out for you to recognize that. So this is the IVC, the eustachian valve, the coronary sinus ostium that has a valve. What's the valve there? What's the name? Yes, the vision valve. Good job, Smitha. And then the SVC here. And this is the crista terminalis here. Okay, and this is the interatrial septum. This is the left atrial view, yeah. And you can see the appendage here, yes, and the septum primum. Remember that we were looking at the way, and there is an overlap, right, of between these two arcades. This is a view of the right atrium. It's very similar to the bicaval view, right? On TEE, you see the SVC, the IVC here, the interatrial septum here, yeah, the LA, and you see the RPA here in the right pulmonary vein, very close to the SVC, right? Okay. So what's the difference between a secundum ASD and a primum ASD? From a very pragmatic approach.
One is from the left to right, and the other is from right to left.
So more than that is the location of the defect, yeah? So we said the secundum ASD is located in the fossa ovalis, and the primum ASD is located at the cracks of the heart. Yes? Okay, good job, Rasha. So you can see them here, right? This is where secundum ASD is usually located, yeah? And then you see where the primum ASD is usually located, in very close proximity with the atrioventricular valves, yeah? So that's where we find the secundum, and this is where we find the primum. And I always tell my fellows that when you see a defect and there is no tissue right cranial to the AV valves, this is most likely a primum ASD. Yes, and then we confirm with different views and associated defects and things like that. All right, so we are talking about atrial septal defects and other defects about the tricuspid valve today. And so I just want to share with you a very practical rule that my fellows are very aware of it. So when we have shunts, it's very important to identify the location of the shunt in relation to the tricuspid valve. Yes? So shunts that happen above the tricuspid valve will lead to what? Enlargement of what chamber? Right, yes. RA and RV, yeah? How about shunts below the tricuspid valve? LV. Okay, so let's think about that now, yeah? So you got it right. So the shunts let's name some shunts that happen about the tricuspid valve that you guys are very familiar with. So remember that we say all the details, right? So ASD alone is not going to cut it. Which ones? Secundum ASD, primum ASD, sinus venosus defect. Yes, what else? Coronary sinus defect or unroofed coronary sinus. And what else? PAVVR. Strong work. So all those defects happen, the shunting happens above the tricuspid valve and will lead to RA and RV enlargement. And those are the chambers that we look at, we focus on when we report, and we look at because those are the criteria are based on the size of those chambers, yeah? So what about defects below the tricuspid valve? VSDs, what else? PDA, that's great. What else? Window, yeah, AP window, aortopulmonary window, yes. And recently in the MRI lab, we had something, my MRI fellows, an AP fistula, yes, that happened, a patient that was transferred here after a balloon dilation of MPA, branch PA stenosis, that had an AP fistula as a complication, yeah. Okay. Well, great. Why do those defects cause LV dilation as opposed to RV dilation?
Because they don't spend much time on the right side. There's more time. They pass through the right side quite fast. So most of the volume of the work takes place on the left side.
So that's a good point. So let's think physiologically. So when you have a defect in what drives flow across a shunt, a hole? Pressure gradient. What's the pressure gradient between the LA and the RA? Numbers. What's the LA pressure in normal? 12. Let's call it 12. RA? Yeah. So what's our gradient? 5. Yes. So that's the driver for our atrial septal defects. Yeah. What about a VSD? Let's say we have a large membranous unrestricted VSD. What's the gradient between the chambers that are communicated by it? Right? What's the LV systolic pressure? 120 in the best case scenario. What about the RV pressure? 20. So the gradient is, like you all said, around 100. So the driver is much stronger, number one. Most of the shunt happens in systole or diastole? Systole. What's the position of the pulmonary valve during systole? Open. So that high pressure jet is going straight to the pulmonary artery vasculature, yes? So that's number one. So you have, similar to what you have in mitral regurgitation, in systole, you have two jets, two directions, right? One, the aorta, right, through the aortic valve, and then a lower pressure chamber. You know, in mitral regurgitation is the left atrium. In a VSD is the right ventricle, yes? So you have jets in two directions, so your stroke volume is being divided in two. So to keep your forward flow, your stroke volume that sees your end organs stable, how do we compensate? What does the LV do? It dilates, right? You increase your end diastolic volume, yes? Right? Just very similarly to what happens in mitral regurgitation, okay? So that's why ventricular septal defects cause LV enlargement as opposed to RV. Like Rasha was saying, the flow just passed through the RV as the pulmonary valve is open. And this particular detail that we don't think about so often is also the reason why a VSD is much more likely to cause what as a complication? Pulmonary hypertension than in ASD. Yes? More and more we believe that patients who have a shunt above the tricuspid valve and develop pulmonary hypertension, they have two issues. They have the shunt, and in addition, they have a predisposition to develop it. But in ventricular septal defects, unrepaired, large, unrestricted, patients are at a very high risk for developing pulmonary hypertension. And that's why even in babies, if you have a baby with a large VSD who is a preemie and is too small to go through an operation yet for a full repair, so what do we do to prevent this overload of the pulmonary vasculature? What do we do, Aquila? A pulmonary artery banding, yes? So when patients cannot get a large VSD repair right away and they need more time to grow, and so a pulmonary band is a good alternative to restrict flow to and protect your pulmonary vasculature, okay? Well, great. Okay, so now we're gonna go through very easy cases for all of you. So remember that young patients with undiagnosed congenital heart disease usually present with arrhythmias. So young patients with flutter, fib, atypical flutters, you need to make sure that you do a thorough investigation to rule out shunts, okay? So this is a 29-year-old with palpitations, and what do you see? What do we see? Diagnosis. Quick. This looks like a secundum ASD, right? The fossa, there is a hole very well positioned in the fossa ovalis there. So I'm just going to show you how we analyze this, right? The diagnosis was quick, but then we need to decide, do we need to treat it? What are the therapeutic options? And all of these things can be planned based on very thorough imaging, yes? When my patients go to the OR or the cath lab, we already have a plan as to what's going to be done, yes? Everybody that works with me knows knows that. So how do we investigate? So we saw the atrial septum. Then we need to look at the rims, right? Here in the 4-chamber view, we see the relationship of the septal defect with the AV valves, right? We have an AV valve rim that it's good, right? Anything over 5 millimeters is good when we think about transcatheter intervention. We see a posterior rim that also looks good, yes, looks adequate. And then how do we look at the other ones? So we do a full examination. These are called oblique sagittal cuts across the atrial septum, you see? And this gives us as a result these images here, very similar to your bicaval views in TE. Yes, and you can see here what is this? Right atrium. This? IVC. Left atrium, great. And this is our atrial septum, and you can see the defect here in all those cuts that I show you. You see the rims. This is the aortic rim here, and I always tell my MRI fellows that it's okay to report a spectrum. Because it's different in different views, so you always report the smallest one, and then the largest one that you see. So it's okay to report 2 numbers and not just one exact number. So you can see the defect here very clear with left to right shunt, and then MRI can help us see the direction of the shunt. Yes, these are in-plane flows. This is a 4-chamber view, and you can see here the left to right shunt by phase contrast. And then I'm gonna show you the same view for this through these oblique sagittals, right? Remember, this was the RA, the LA, this is the atrial septum, and here you can see the in-plane flow. So what else can we show our referring doctor with phase contrast? My MRI fellows? We need to definitely the cubic to QS, yes. And just to further characterize the anatomy here, we usually show through plane flows. And we show the same images. I don't have time to show all the images modalities, but we do the same with echo with 3D. So you can see here, this is the atrial septum here, and you can see the ASD located right here. And this is true plane. It's very informative, especially when you're considering transcatheter interventions, to know the shape of the defect. It's like putting everything all together. Sometimes you see a secundum ASD, but you don't see the end of it. This is very helpful. We have some patients who have very large defects that extend all the way to the IVC, that have a physiology similar to a common atrium. So this is very helpful for that. Okay, so like Abu was saying, we need to report the defect size. We need to measure the rims, and then we'll review that in a minute. We need to report the QPQS, hemodynamically significant or not, and it's important that you make those statements. So a QPQS over 1.5 is hemodynamically significant, and you need to state that on your report, right? Because these reports are reviewed by different types of providers, cardiologists, but also oncologists that are doing studies for chemo and things like that. So it's very important that you make your assessment at the same time. Then the RV size, in MRI, we use RV end of diastolic volume index to VSA. When the patients have a very high VSA, this index number can be misleading. So what else do we report? Yes, Amber. So we report the RV end of diastolic volume to LV end of diastolic volume ratio, yes? Because sometimes we have a patient with a borderline RV size, but then because the VSA is so elevated, so this is very important in obese patients, but then the RV is 2.5 times the LV size. So in that case, we're just underestimating it due to VSA. So I make that very clear in my statements. Pulmonary veins, the main reason to obtain cross-sectional imaging, we obtain cross-sectional imaging in all our patients with atrial septal defects. This has been a change in practice. Before, it used to be everything was led by echo, but one of the main reasons to do this is to make sure that you don't have an associated pulmonary anomaly, pulmonary venous anomalies, PAPVR, okay? And this is in the guidelines, and we have several patients that were operated a long time ago that had an undiagnosed PAPVR that was not repaired at the time of surgery. Yeah, and then we always need to look for associated defects. And you don't know if you don't know what you're looking for, you won't understand what you're seeing. So it's important for you all to see, to know, and keep in mind what associates with what. And congenital heart disease begets congenital heart disease. So finding one defect, Carlos told me this concept of sufficiency of findings, that once you find one defect, you're all happy, you made a diagnosis, this is why the RV is dilated. But finding congenital heart disease, once you found one diagnosis, that should prompt you to look for all the others. So anomalous pulmonary veins, PDAs are very frequently missed. And it's very easy to look for them by echo and by MRI. So just don't forget. So why do we report the rims in secundum ASDs? Because these are the only defects that can be closed via transcatheter, right? At this point in time in the United States. And this is likely to change as the technology, the experience for sinus venosus defect closures increases in other areas of the world. But right now, for your boards, the only one that we close transcatheter is the secundum ASD. The defects need to be less than 40 millimeters, just because of the device sizes that we have available. And the rims needs to be over 5 millimeters. That's an adequate rim, 5 or more. And the most important rim is which? So I hear aortic. Posterior. Yes, good job, Sita. The most important rim is the posterior, and you have to think about this. And the most popular one is the aortic, as evidenced by all of your responses. But what matters here, if you think about the atrial septal, the atrial septal defect as a pizza with slices, you can see that the aortic rim is a relatively small slice, and it's deficient in 10% of the population. And it's not a contraindication for transcatheter closure, okay? Because if you have a deficient aortic rim, but you have a solid posterior rim that you can see here, this is the largest slice of the pizza. Your device will anchor here and will be stabilized here and won't erode in the aorta, which is where the popularity of the aortic rim comes from. Okay, so when you're reporting, I usually in my summary I make a point to say if one of the defect of these two main rims is deficient. Because it has therapeutic implications. And I specify how much they measure. And if I say the aortic rim is deficient, I follow that by saying, but the posterior rim is adequate and measures 15 millimeters. So this is a patient that here at our institution, we will close per transcatheter. Okay.
What happens to the seal if you have an aortic rim that is deficient?
So sometimes you may have a residual defect, but when our objective when we're closing an ASD is reducing the volume overload. So if you get your QPQS from 2.3 to 1.2 because of a tiny residual, we all can live with that. And sometimes we discuss this with the patients, and they always prefer transcatheter when it's an option. Understandably so. So we bring this up. This also happens when, that's why the through plane view is very helpful. Sometimes it's not a perfect circle, and we know that there is an area that may not get covered. So we anticipate that. We disclose that to the patients. We tell them that this is not going to be hemodynamically significant, but it will be there likely, and share decision making.
Is there a through plane 3D?
Yeah.
No, not flow, but anatomic.
Yes, there is, but it's less obvious, I would say. We can obtain that same view, but I think the flow really makes it evident in MRI. We do those on transthoracic echo. Alicia, I guess, yeah. Yes. The MRI, yes. But we do with phase contrast, and phase contrast for this is just all about the planning and the angle, and we're fortunate we have here some of the best CMR technologists in the nation, in my opinion, and they really have it down, and they will try until they get the perfect angle for the flow to show it to us, and it's very quick. Phase contrast can be achieved, can be obtained very fast in the MRI scanner. And okay, all right. So we talk about all this, and then the AV valve rims. Okay, so yes. Well, it doesn't. I really try to find the moment where I see it with more clarity. Yeah, oh yes, sorry. Dr. Sogwe here is giving me pointers. He wants me to repeat your question though. So which phase, he's asking if it matters which phase of the cardiac cycle we measure the rim. So really, I just scan through the whole cycle. I find the moment where I see the rims with more clarity, because remember, these rims can be very mobile, and then I measure the largest I get. When they're very thin and very highly mobile, I do comment on that. When I have a rim that may be 6 millimeters, but it looks that it may be hard to anchor a device there, I do make a comment to that to make sure my receiving physician goes and looks before they refer for transcatheter. Okay, so then we don't assess all the shunts. We talked about this, and all the shunts are different, and they vary depending on the location, the pressures in each chamber. The pressures in each chamber, they may be different as the natural history progresses, right? We said that in a normal patient, the gradient across the VSD is 100 with a normal blood pressure and normal systemic blood pressure and pulmonary pressures, but this can change as they develop pulmonary hypertension, for example, yes? So how do we approach the shunt, the QPQS, the quantitative assessment, which is one of the strengths of MRI? How do we do that in ASDs and VSDs? Yeah, this is a very simple questions. My MRI fellows can enlighten us. How do we calculate QPQS by MRI? What do we measure? Yes. So we divide the flow across the, Anish? The PA, and we measure that where exactly? Okay, and then divided by, so that's the QP, yeah? And the QS? Aorta, right? Easy, ASD and VSDs. In the absence of other associated defects, this is how you do it, yes? What happens when we have a PDA? Huh? Yes. So yes. So Isa and Rasha are telling me that I flip my numbers. Why do I do that? That's correct. Yes, yes. So that's exactly right. So that's it. So we use the aortic flow as the QS, right? In a patient with a PDA, when I measure the flow at the aorta, does that represent the QS? Does that represent where my systemic capillaries are seeing? No. Why not? Because after my measurement point, I'm losing some of my forward flow because it's going where? Back to the PA. Similarly, when I measure the flow in the pulmonary artery, does that represent my QP? No. Why not? Yes, because my QP will be that PA forward flow plus what I'm getting from the PDA. That's what my capillaries are going to see. Yes? Okay, so you understand why I cannot use the usual. But why can I use the aortic for that? Exactly.
It's both coming back through the pulmonary veins to the left circulation.
Exactly. So in the absence, always is like this, in the absence of other defects, right? The pulmonary artery forward flow plus the PDA flow is going to go through the pulmonary capillaries, go to the pulmonary veins, and I could measure my QP there, as adding all the pulmonary veins. But in the absence of other defect, all that flow is going to go to the LA, LV, and aorta. Yes? So this all changes if you have an ASD. So we already covered that. Now number 3. And then when you have complex anatomies, Fontans, single ventricles, and this is whenever shunt assessment gets confusing, what can we use?
The other end of the circulation, the venous circulation.
Yes, that's right. How? How do we do that?
We use the pulmonary veins to detect the pulmonary circulation.
Right.
IVC plus the SVC.
So you're telling me we measure each pulmonary vein. Yes, to calculate the QP in a complex anatomy, we obtain the flow in each pulmonary vein. That this is extra work and extra time in the scanner. Yeah. So and we add all of them, and that's the QP, right? Because that's the blood flow that's coming from the lungs. So whenever you have too many defects and you don't know what to do, this is the right way to get your QP. But you need to be very alert and near the scanner. When we're doing this, the techs will call me and we review them, because when the patient is gone, then you may not be able to calculate it if one of these measurements are wrong. Yeah. And then the QS? IVC plus SVC. Why? The IVC sometimes is very dilated. It's hard to get a good measurement because of the hepatic veins. So if my IVC measurement is a little unreliable, what do we use instead? The descending aorta, right? Okay, great.
What happened to LV stroke volume?
In which case?
Where you have to go through 4 pulmonary veins.
Mm-hmm.
That flows go to the LV.
Mm-hmm.
Unless you have MR.
Yes.
AR,
Yes.
then LV stroke volume can fill in.
They have VSDs and all the other stuff. Good people have everything.
Yes. So.
Yes.
Yes. So here we're simply measuring what is coming from what got through the pulmonary vasculature in the pulmonary veins. Yes, and that's the way we try to keep it clean when we have some patients that have a common atrium, a VSD. Yes, just Yes, no coronary sinus to the yes, all sort of things. Yes, so that's the way to tease these apart. Yes. Okay. Well, great.
And what's the error
Mm-hmm.
that you would expect? Is it like a 0.1 of that ratio of shunt?
Yes.
Or, what is
Yeah.
the
So
usual thing?
So MRI is in the right. You have to have very well trained. It's just like with echo, you have to have a very well trained sonographer. But MRI is very accurate when measuring flows in vessels that are circumferential structures that you can isolate from others. So So in general, when we correlate it with the in the cath lab, we here at our institution have great correlation with MRI QPQS, even in complex anatomies with a cath QPQS. Sometimes there is a slight difference and it's related and it's really not significant from a physiological perspective. When the shunt is significant, the correlation is very good, but you give sedation to the patients in the cath lab, so their SVR is lower, so the hemodynamic conditions sometimes are different. So we attribute that to that, yes. So you all remember, this is just for the boards, remember that, as I said, the cross-sectional imaging, CMR and CT, or TEE, if you feel comfortable assessing all the pulmonary veins with TEE, are important to evaluate pulmonary venous connections in patients with ASD. When do we replace? We need to, in patients with symptoms, ASDs this is, symptoms, all ASDs, symptoms, RA and RV enlargement, all defects above the tricuspid valve, I should say. Symptoms, RA, RV enlargement, and hemodynamically significant QPQS, over 1.5. Usually, these things come together. I always tell my fellows that congenital heart disease may be complicated, but if you're accurate with your measurements, things make sense. If you have an adult with a QPQS of 2, the RV is going to be enlarged. In general, that's what it's going to drive all your workup. So not too many controversies when assessing septal defects. For primum, and sinus, venosus, and coronary sinus, all of those same criteria, same are symptoms, are right-sided charmer enlargements, and same QPQS. But they're always surgical here for your boards today. You always need to make sure that the pulmonary artery pressure is less than 50% systemic. That's how we work in congenital heart disease, and that's because we think about the direction of the shunt. And the PVR less than 1/3 systemic. Yes. So in other patients who don't have any symptoms, but are having concomitant cardiac surgery, we take care of that. Another thing I'm gonna add after this, so we don't close when the patients already have right to left shunt. In those cases, the PVR is high enough to have reversed the flow, the shunting. So when the shunt is predominantly right to left, this is a patient that most likely we will never close, and we'll deal with the other physiology, this with Eisenmenger medical management, right, with bosentan and iron repletion and things like that. But then we have a gray zone where the pulmonary pressures are not normal. They are above the cutoffs, but then the patients still have predominantly left to right shunt. In those patients, they can be treated. We have an approach called treat to close. So usually we work on them for several months with medication, pH therapies. So we start with one agent, then we add another one. We do echoes to assess the pressures, and then we do caths. And then we close when the pressures are acceptable. Before closing, we do test occlusion and measure all the pressures with a balloon occluding the ASD to simulate this, because sometimes the pressures are fine, but then when you test occlude, then you challenge. And then another thing I'm going to add, especially for us, that we're adult cardiologists, more and more we're treating patients who are in 60s, 70s, and in those patients, closing an ASD has other implications, but for the left side. Yes, to give you an extreme example, I have a patient with HCM, hypertrophic cardiomyopathy, with restrictive filling, who has a large ASD, and he had pulmonary hypertension. We treated, we got the pressures where we wanted to be, but then on test occlusion, what happens to the wedge pressure? Do you guys, it went up to like 30. So what will happen if I close that defect for that patient? Huh? Well, with an acute increase in your wedge to 30. Yes, this patient is gonna flash. Yeah, so this is not an ideal. We elected not to close that patient, and we're looking at other advanced ways to manage his with transplant. Yeah, so very in a very in a more day to day patients who are in their 70s, you need to who with diastolic dysfunction is very important not only to look at the PA pressures and test occlusion, but also to look at the wedge. Yes, in fact, the wedge can make an increase in the wedge can make your PVR. If you're following me with the calculations, it can make your PVR look better falsely because the contribution is mostly from the wedge. So as you increase it when you calculate your PVR, so mean PA pressure minus wedge, so that number is going to drop. Yeah. So be very aware, diastolic dysfunction assessment in patients who are at risk before closing, test closure, and very watchful post-procedural monitoring or post-surgical monitoring for that. This gets can get even worse in patients who are hypertensive, and we've had patients that have flash. What is a way that we can plan ahead of surgery? Let's say this patient has diastolic dysfunction. We are concerned about the wedge. What can we do? So post-operative, let's say this patient is going for surgery to minimize that. With the patch, when we put the patch, do we occlude? We do fenestration, yes, and Isa recently helped me with a patient in that circumstance. So, in these cases, the LV and the LA is using this ASD as a pop-off. And when you completely close it, then your right side is happy because the volume is down in the absence of pulmonary hypertension, but the LV struggles. And then you have a very rocky post-op with pulmonary edema and things like that, prolonged ICU stay. So a fenestration, just like we were discussing earlier with Dr. Zogby's question, when either of the chambers have a high risk of being dependent on the shunting, right? And increased PA pressures that you treated but may not be perfect, or LV dysfunction, this heart depends on that shunt as a pop-off, either way. So leaving a fenestration is a great alternative. So moving on, this is also in a very young patient with flutter. After this, you guys will be so ready for the boards. The very frequent presentation is with arrhythmias. At a young age, you find the congenital problem. Yes, so what does this patient have? A primum ASD. Yes, you see that the defect is, so we see the fossa ovalis here is intact. The defect is at the cracks of the heart. There is no tissue between the AV valves and the defect. Yes. Yes, and then anything else you would like to point out? MR is does it look central, eccentric? Yeah, so I'll show you a little picture of a little investigation of the mitral valve there for you to look at. And here, this is the mitral valve on short axis. We see this beautifully also on 3D echo. Alicia is an artist. So if any of you want to learn transthoracic 3D assessment of the AV valves, really, Alicia can show you everything you need to know. So you can see the cleft here, right? Yes? Yes, and I'll show you with some color flows that we can do with some MRI software. All right, another one. Another challenge. So this is an axial stack, so we're cutting through the chest down. These are sinus. So this is a patient, very, very, very large right ventricle on echo, difficult windows, and all right. So I went once. The RV, you see any objections that is very big? So very dilated, very positive vowel study, they tell you. But cannot identify this defect. And I want to clarify that this defect can be identified by echo, in the right hands and with the right windows. So, yeah. Yeah, so I cannot control this as I usually can. So we're gonna follow the SVC down, okay? This is an exercise we do with the MRI fellows all the time, right? We find the innominate, we find the SVC, this is the azygos, we follow it down, PAs, and then you see that there is a defect here between the posterior wall of who? SVC and who else? And the anterior wall says an inch of the pulmonary vein. So exactly right here, as the right upper pulmonary vein courses towards the LA, you see it's back to back with the SVC, and that overlapping area portion is where we find, when it's deficient, we call this what? A sinus venosus defect. Okay, and Tyree is telling me to finish. So this is where we measure it. This is where we close it. And I'm going to skip a few things here just to show you another one before we finish, okay? I'm just going to skip the post-surgical of this because I want to show you. Sorry. Okay, so we're going to talk about this one really quick, two images. So because otherwise we never get to it. So the coronary sinus defect, is it truly an ASD? No. Before that, the sinus venosus defect, is it truly an ASD? No. Why? It's because the atrial septum is intact. When they send you this patient and say, but the atrial septum is intact, they are right. The defect is elsewhere. Physiologically, they behave the same way. Yeah. So where is the problem in a coronary sinus defect? Huh? That's right. So that's right, Smita. So as the coronary sinus courses in relation to the LA, behind the LA, back to back, in that overlap between the posterior wall of the left atrium and the anterior wall, if you want to say, of the longitudinal coronary sinus, that's where the defect is. As you can see, well, it's hard to illustrate. so they can be very extensive, where you don't see any coronary sinus wall, or they can be localized. So that's why you need to do sweeps and a very good examination. And just like we do oblique cuts through the atrial septum and in the 4-chamber view, for coronary sinus, and this is a great tip when you go in practice, it's very important to do cuts across the longitudinal coronary sinus and to obtain 2-chamber views, because if we do it here, you're going to see a full wall, but then if you have to continue trying to find where the defect is. So in MRIs, it's stuck, and in two more images, Tyree. So I need you to pay attention to this. So we're injecting saline to the left arm. So which chamber enhances first? Left chamber, right? So we have a patient with a persistent left SVC. We're injecting in the left arm, and the first chamber to where we see the bubbles is the left atrium. This is an unroofed coronary sinus. So that's a trick that you can use in your labs, but without a persistent left SVC, it gets a little trickier. So provided you have that, you can do this and you have your diagnosis.
It's not a very unusual combination.
So we see it frequently, the less FTC in coronary sinus. We do see it, but you do need to scan for it. So you're suspecting, you look for it, and if you see it, yes, but we do see that combination. And then but if you don't have that, then you rely on Doppler and sweeps. So this is Alicia's art, and you can see how she is sweeping to show you that there is a defect. You see the anteriorly where you see the aorta, you don't see it. The fossa ovalis is intact. There is no primum ASD, right? Because you see here that is intact over there. But then you see very posteriorly, you see the defect there. Let's see here. Coronary sinus, and that's that. So it's not truly a defect in the atrial septal wall, it's the coronary sinus ostium. So the flow is going, so the jet is coming in these patients. They come in from, so we use this as a channel. So the LA has higher pressure than the coronary sinus. The flow enters here and comes to the RA through the coronary sinus ostium. So that's something very important for you to understand. And then I'll show you some more images here. And here is where you see that the LA is in full communication with the sinus, and then that the ostium is the pathway, is a pathway to the shunt, yes? So in these patients like this, where it's so extensive, we can just close here, just like we would close an ASD, and we leave them with a little shunt. So instead of repairing the coronary sinus and patching the deficient areas, when it's very extensive, we just close the coronary sinus ostium, and then we leave the cardiac veins drainage in the LA, so our patients live with a lower saturation, but it's an easier surgery. If it's very localized, then you can patch it, but just closing the ostium will take care of the shunt.
What would happen to coronary sinus pressure?
Yes,
Which is important for coronary perfusion.
yes, it is important. Yes, it is important, but it's a minor sacrifice. In congenital heart disease, we make compromises all the time. All right, okay, so. That's right. Okay, so we went over all the points as we went. So ACHD care for life. We care for them forever. We image them forever because complications happen.
For that diagnosis of unroofing of the coronary sinus,
Yes.
from an echo point of view,
Yes.
should be short access of the coronary sinus.
Yes. And the same thing in
Otherwise,
yes.
you're not going to be able to diagnose.
Yes, and the same thing in MRI. Yes, we do short axis stacks of the coronary sinus, both. But in echo, the equivalent to the stack is the sweeping. So yeah. Each modality with its tools.